So as Christine said, my name is Andrea. I'm a pharmacist from St. Clair's Hospital in Denver and Gilbert. I've been with them for around 5 years. So I was asked to come today. I was actually here a few months ago to just review about medications, and today they asked me to come again. So we'll just do a brief review or brief overview of medications out there. As we know, everyone with osteoporosis, they may or may not be on these medications, but there are options out there for you depending on your different risks, your sex, your risks, and of course of your preferences as well. As we'll go through, there are oral medications as well as injectables. So we'll just go through the different medications out there and then just side effects to look out for.
Sorry.
Medications? None?
Yeah, I am.
Oh. Do you mind sharing which medication you're on?
So I had cancer 2 years ago. I'm on tamoxifen.
Okay.
I am on almost statin. I can't even pronounce it.
Okay. Are you on any osteoporosis?
No.
Okay. All right.
My wife Becky's on Prolia.
Oh, she's on Prolia, the injectable?
Yes.
Okay. How long has she been on?
About 5 years now.
Okay. So we'll talk a little bit about that.
Yeah, that's one of my questions I was asking. Related to that.
Sure. So on the handout that I gave out to you all, it's just, So on the handout that I handed out to you all, we'll just go through a basic overview of the background, the different medications, calcium and vitamin D, as well as there's 2 different varieties of medications, your anti-resorptives, and then your anti-resorptives, and then your anabolic drugs. So just as a background of osteoporosis, it's just your disease state of fragile bones. It's caused by the slow and steady weakening of your bones through the skeletal remodeling process. So basically your skeleton is building up and breaking down, and osteoporosis is just it's just in that process there's differences in it, and then it just slows down. Either the beginning process of your bones building up slows down, or the breaking down process, there's like a problem with that. As we age and grow older, just because your bones may become weaker, so that's why, or that may be a cause of osteoporosis as you get older. So when you're diagnosed osteoporosis, it can't be cured, but there are many preventative measures to keep it from progressing, like your regular exercise, diet, and then calcium and vitamin D, which we'll be going through in order to prevent falls from occurring. So as I mentioned before, considerations of your meds include the severity of your osteoporosis, your sex, age, cost, medical history, as well as other risk factors and your personal preference. So the first thing we'll be going through is your calcium and vitamin D. Are you taking, or is anyone here taking calcium and vitamin D?
Yes, I am.
Okay, perfect. That's basically the main thing that you guys should be taking. Since calcium is the building block of your bone, and then it comes in many different forms. It comes in your calcium carbonate, like your Tums, or calcium citrate. There's Citracal out there. So it's just important to check the serving size and the amount of the calcium in that in like whatever form you're taking it, just because there are different forms of calcium out there. So does anyone mind sharing what kind of calcium they take, or which calcium brand that they take? Do you take calcium carbonate, calcium citrate, or do you not?
I'm not really sure, but I buy at Costco.
Okay.
Yeah.
Yeah, because
Mine just calcium with vitamin D. Some
Caltrate.
Oh, the
I'll
Caltrate.
take care of
Yeah.
Caltrate.
And mine has zinc in it as well.
Okay.
So I don't know.
Okay.
That's additional help.
It's additional help. It also helps with your immune system, the zinc as well. And the Caltrate that you mentioned, it is a good combo product.
I take one time of the bottles when I finish that, and then I switch to the one that has also the magnesium in it.
Oh, okay.
So calcium and magnesium
Okay.
because of the cramps.
Yeah. Does the magnesium help? a
Yes.
lot? Okay. So some of the calcium products you do have to take with or without food because they might cause upset stomach. Like if you take Tums as like a calcium supplement, you just have to be aware that you have to take it with food because that helps with the absorption of it. If you take calcium citrate, which is in that Caltrate that you guys take, you don't have to worry about food. So it shouldn't affect the absorption of the drug itself. So it's just some things to be aware of depending on the type of calcium that you take. But on the handout, I put here from the National Osteoporosis Foundation. It just gives like a little rundown of how much calcium and vitamin D you usually should take daily. So for adult women, 50 and over, the calcium, your daily content should be around 1,000 to 1,200 milligrams a day, as well as for vitamin D. I know a lot of people take 1,000 units. That's usually the standard, because the vitamin D, usually people take vitamin D3, and that's like the daily dose. So usually it's around 1,000 or 2,000, but the recommended daily dose is 1,000. And then for adult men, it's around the same, the 1,000 to 1,200 mg of calcium, as well as around roughly the 1,000 milligrams of your D3.
Is there a difference? I mean, like we're all taking kind of calcium, but different variations of calcium, citrate or whatever. Does it make a difference?
Overall it doesn't, as long as you make sure you're taking the right amount, because some of them have different content, like your Tums, they only have like 500 milligrams per tablet, but calcitrate, I think there's literally 600 milligrams. Yeah. So it's just good to read the ingredients, just to make sure you're getting it.
And what if you're eating a lot of milk, eating a lot of cheese, like would you then not take one of these supplements? Or
So it really depends, because sometimes like the milk, you don't know how much calcium you're actually absorbing from it, just because with food it's very unpredictable how much you're eating, and maybe like you have an upset stomach. So it really all depends on diet. Yeah, like if you're eating a lot of milk, then maybe you can back down on the calcium, but it's just.
so could you have too much calcium? Like if you have too much, would that cause a problem?
You cause hypercalcemia, but that's pretty rare. Yeah, it's rare.
Not to worry about that.
No, if you're taking those over-the-counter like supplements, you would have to take a lot, not just like once a day. Like maybe take you would take a lot. You would have to take a lot for your body to absorb it all.
You know, when you take over the dosage, the body doesn't absorb, it flushes it out. So it really doesn't stay in your body anyhow. That's what I was like.
It's good.
Well, yeah, cannot overdose on that.
Yeah. Unfortunately.
Thank God.
All right. Any other questions of calcium and vitamin D?
I used to take Boniva,
Okay.
and it really was not a good experience.
That's a prescription, right?
Later bisphosphate.
I used to feel like I had the flu. My
Oh,
whole
flu
life,
symptom.
I couldn't lift anything, and I'm pretty strong. And I couldn't lift anything. That's the Sally Field one. That was the advertisement. Boniva.
Did you take anything after they switched you to something else after?
I just take vitamin D3.
Okay. That's good. That's
Yeah.
supplements. Yeah, because sometimes we'll touch about that later. There are like side effects that you could get from the prescription drugs that may make you stop taking it. So it just depends on your doctor, what you experience. Because they do have their benefits, but they also, like any medication, they do have their benefits, but then you always have to remember they have risks as well. So side effects. So it's just always a balance of those two, and also a discussion with your prescriber, your physician, whoever you're taking care of you, just to make sure you can get that right.
Yeah, that's what stopped me from taking anything for the osteoporosis.
Yeah.
Is all the side effects. So far, so good.
Yeah, as long as you are like exercising, taking the right supplements, like your calcium, vitamin D.
Right.
So as long as you're preventing yourself from falling and breaking bones, that's like the biggest thing for osteoporosis treatment. Like medications is just one part of that, but it's a whole encompassing thing.
The other stuff.
Yeah, it's the other
Don't sit
stuff.
on the couch.
There was a drug that was mentioned in the class, exercise class prior to this. Did you-
Madeline.
Yeah, Madeline mentioned
Yeah.
something that it, whatever she was taking, it deteriorated her jaw, she lost 4 teeth.
Yeah, it wasn't one of the.
Was it Fosamax?
No.
Was it
different.
I had to stop
Relaxafen or
Fosamax.
something? Relaxafen? It was a generic and a
And
name
the-
brand, like a Vista or something, remember that?
Yeah, the Vistas and the other one.
And
was
Relaxafen.
But it was the same
One's-
thing.
Yeah.
Yeah, Vista, your estrogen, it's like an estrogen.
Hopefully
It's like
my
an,
Joe
what is it?
or my phone.
Was it in here?
Yeah,
No,
it's one of the estrogen therapies.
What about the other name of the genetic, that it's exactly the same thing, similar?
It was
So
a name brand and a generic, right?
Yes, that's
They
what
were
she was
equivalent.
taking both.
And she,
One time, like, and then they switched the
They switched it to
genetic,
the-
because insurance wise.
But technically, they're still the same anyway.
That's what she said, yeah. That's what she
the
said.
compound's the same, but one's generic, one's cheaper. But she lost 4 teeth because her jawbone deteriorated.
That's a very rare side effect, unfortunately, what she did.
She will just said it to everybody, make sure that she'll learn the hard way, unfortunately. I think it was called Relaxafen with the,
I don't remember the name.
Vista and Relaxafen, I believe is what she did. Okay, that's for estrogens?
It's one of the estrogen.
I guess I don't have to worry about that.
Like for women, so.
But she was not taken yet for that. She wasn't because she had cancer. But she was.
Yeah, she did have some kind of breast cancer.
That's what they.
One of the side effects is increased vulnerability of breast cancer. Okay.
Wish she was here.
That's another thing I don't have to worry
She
about.
I know, it's unfortunate.
Yeah.
It is unfortunate with the side effects, because some of the estrogen therapies, they may cause either, they have an increased risk of blood clots, they're not meant for people who have history of breast cancer, so we'll get to those after.
There it is. If you have it in the second page.
That's the, okay, that's the one.
It increases bone density, reduces risk of spine fractures, but apparently deteriorated as well.
Okay. So we'll go through those after we go through the first category. So actually those, what you guys were talking about, the Raloxifene, that's under the first category of drugs we'll go through, which are your anti-resorptive drugs. So for the prescription medication, there's 2 categories. There's your anti-resorptive drugs that slow the rate of your bone loss and breakdown, while you have the anabolic drugs, which are your injectables. Those speed up the process of bone building. Most people start off as the first-line therapy with your bisphosphonates. So these are like your Fosamax, your Boniva, your Actonel, and then your Reclass or your zoledronic acid, which will be the injectable. These are usually first-line therapy.
My oral surgeon for my teeth.
Mm-hmm.
Here I was on Fosamax. He said you get off that immediately
Yeah,
and do not let anyone talk you into taking it.
because of that side effect.
He
So
said it really hurt you. It hurt my teeth.
yeah, it's like this rare side effect to be aware of with the bisphosphonates. They could cause uveitis or inflammation or osteonecrosis of the jaw. So it's like death of bone cells or tissue. It's called ONJ, so osteonecrosis of the jaw. So it's basically you have to take good dental care, but it's a very rare side effect, but it could happen. So that's why, like you were saying, with your dentist, since you were on it, they just wanted to be careful just because you're on that medication, because it has an increased risk of this might happen with your jaw and your teeth. That could cause breakdown. So that is something to be
But then
aware
my
of.
sister-in-law, she was taking Fosamax because of the acid reflux that she had. Doctor gave her that, but they put like, she had a holes in her stomach, like the stomach, the lining of the stomach.
Oh, so the
Yeah.
Fosamax
She had
is
to
for
stop
that.
taking that, yeah.
Oh, okay.
I mean, it's very,
I know some things could be used off-label, but then they also have those different
you know.
side effects to be aware of. Like the oral forms, like your Fosamax, your Boniva, your Actonel, they may have your GI side effects like heartburn or trouble swallowing. So you might have to take something else like for that, like Nexium or omeprazole. But it's also good to take these prescribed on an empty stomach with plain water 36 minutes before lying down if you are on these medications, just to help them get absorbed more. But is anyone actually on bisphosphonate, like any of these medications, these oral ones? No? Okay. So when we brought it
I
up,
hate for you to be down.
no, don't worry. Because it's always good
But
to be aware.
then my doctor put me on something else, and it was an A name, I forget, and I had stroke.
You have stroke from it?
Not a big one, you know.
That's a stroke.
Like an
Yeah,
increased
I
risk
had,
of clot.
I had one of those, one side, everything went down one side, and then within 20 minutes, I was like fine again, but the doctor said,
Yeah.
Something transient.
yeah.
Transient.
But he said it would prevent this other one, after the Boniva, I got over that. I went on this other one, with an A, and the side effect there was, of course, osteoporosis.
Well, there's something called, is it Actonel?
I know that I don't remember.
It's on this chart. Okay. Or,
I see it's on the second page here.
or there.
Yeah. And I just, that's what I have to be a Debbie Downer. I eat a lot of greens.
No, it's good you're here now. It looks like you're doing well.
Thank you. I just,
Yeah. A stroke is a stroke, big stroke.
you know what, when I went to the doctor, that's what I said. He said, why did you go to the hospital? And I said, because everything started coming back again. He said, you had a stroke. I said, no, I felt better, you know.
Probably could he check it up, get
He
checked,
said,
make sure it
the
doesn't
next
happen again.
time, if there is a next one, go straight to the hospital.
That's true, even though like
It's embarrassing to go to the hospital.
I understand.
No, bring it down, check it out.
Yeah.
It's your life.
It was a A-name, after I was taking something, and then it was an A-name, and it finally
big name.
Actonel or Altiva, I don't know. But I know that it was one of the side effects. But he also said it prevents breast cancer, and that's why, because it's hard to get me on medicine, I don't like taking medicine. He says, oh, this is all good. The minute I had that, we'll go to the level that medicine.
It might be one of those estrogen medications, because those estrogen agonists, like, anything with
If I
estrogen
take
in it.
estrogen, I'm like
Yeah.
another biopsy. I'm like a factory reject.
No, I understand.
And everybody is individual, and that's why, right, medications can change, and
Yeah.
they
you
can
know,
change
it
us,
depends
and
on
we
the
have to
person.
be aware, you know, what we're doing, and listen to our bodies, right?
Yeah, because one thing that may happen to you might not happen to someone else, so someone might like totally benefit from one drug, while another person gets all the bad side effects that are just those black box warnings that are very rare. So it's like, it all depends on the person, honestly.
Thank you for sharing that.
Yeah, I appreciate you sharing it.
Thank you.
And it's good to see you here. I know it's doing well.
I know, that is true, yes.
Any other questions about the bisphosphonates, the side effects? I know there are a lot of them. All right. So we'll go on to the second line therapy that's usually recommended. It's out there. It's called Prolia, or your denosumab. It's your injectable. You get it every 6 months in a doctor's office, so you can't give it yourself. It's recommended second line for those people where your bisphosphonates, like your Fosamax or Boniva, they don't work very well. So basically, this is like your second line option if you want to go that route. So basically, you have to watch out for calcium levels, skin rashes, and then if you have a weakened immune system, you might be, if you're on other drugs that suppress your immune system, like cancer drugs or other immunosuppressive drugs, if you have like lupus or something like that, just be aware because you can have an increased risk of infections if you're on this drug as well. And then just common side effects of your Prolia are just joint and muscle pain. There's nothing really major like those black box warnings that you hear of with Prolia. So I guess that's a good thing about that. So going further is
Excuse me,
your,
is there any limit to how often they, or how long they can take Prolia?
so just like the treatment in general, with Prolia as well as your other drugs, there's really no length of treatment out there that says like, oh, you're going to be on this like for 10 years or 5 years. It just depends on how you're reacting to it. Like if it's helping you decrease the risk of your falls, like if you haven't fractured anything while on it, and then if you're taking those bone density tests to measure that
Right.
regularly, if it's like not, so if it's staying stable, then it's helping you, basically.
Like, I'm curious, because Becky was on request,
Yeah.
and then after so many years, they said that's too long, and they moved her to Prolia. So I'm wondering if there's a break on that also. It doesn't look like it, doesn't sound like it.
No, there really isn't a set time period. But with the other ones, like your Fosamax or your Proniva, some people say that they take a drug holiday if they're on it for like 3 to 5 years, and then like nothing bad has happened to them, like they have decreased risk of falls or something, then they can take a little drug holiday from it, and then just see how they do without it. But those drugs last a long time in your system, so then there is no set time of how long the drug holiday is, but you can be off it for either a few months or a few years, but then you'll have to eventually go back on it just to help decrease your risk of fractures and falls. Any more questions? Yeah. So moving on, there's calcitonin. This is no longer considered a first-line treatment, but it is still on your list of osteoporosis medications. Just be aware of it. It comes as a nasal spray, as well as, I believe, a tablet, but the nasal spray was the one that was most prevalent, so it just slowed bone breakdown and increased your spine bone density. And this was only for women 5 years post-menopause. And then going further down are all your estrogen therapies. So some are not recommended for women who have breast cancer or have a high risk of breast cancer. And then there's also the increased risk of hot flashes, leg cramps, increased risk of breast cancer, strokes, and blood clots in a lot of these estrogen therapies. So a lot of them are listed here on the list here. So it's just like a lot of estrogen. You have your raloxifene or your Evista, as well as this conjugated estrogen, which is your Duavie. So all of them come in tablet form, and they're taken usually daily or like a few days a week. And then because they're estrogens, they are only for women. So that's something to be aware of with those. But the big ones with those are the increased risk of blood clots, if you ever are on them. Sorry. No. So, yeah, so like DVTs, if you've ever heard of those, or like a PE, so a clot that can go to your lungs or stroke. So those are increased risks to be aware of with your estrogen therapies. And then going to the second category of drugs, we just went through those first categories, which are your antiresorptives. So we'll go through your anabolic drugs, which are your 3 injectable drugs. They can be self-injectable. 2 of them are for 2 years and one's for 1 year. So these help speed up the bone rebuilding process. Usually these aren't first line, they're more like down the line, since most people start on the bisphosphonates, like your Fosamax and your Boniva, and they work your way down. But it's just good to be aware of these, and they're much newer, so think of insurance as well. They may not be generic yet, so they might be a little more costly, just because they're injectable as well. So the first one is your Forteo, and that's your daily self-injection for 2 years. And the second one is your Tymlos, which is that abaloparatide. So this is also injection for 2 years. And then that is not recommended if you have an increased risk of osteosarcoma. And then the third one is a newer one called Evenity, which is a monthly 1-year injection. So this one has a box warning of increased risk of heart attack, stroke, and other complications with your heart. So I don't know if anyone's on these injectables. I'm guessing not. But it's just something to be aware of down the line, that they are newer therapies.
Question.
Yeah.
If you're supposed to take the injections for
Yes.
2 years, at the end of the 2 years, you should be all right it should cure you?
So there is no cure. So it's gonna help, but then they say after the 2 years, you have to switch to another therapy to like.
So you're constantly on drugs?
Yeah,
Okay.
basically.
So they're not fixing the problem?
It's not really fixing it, it's preventing further problems from
Okay.
occurring. Yeah. That's basically what most of the drugs are, since there is no cure, sadly. But it's just like taken in addition to your exercise, your diet, just to prevent you from
Right.
having falls. So, yeah, with those ones, since there is a set time, unlike the other ones where there wasn't really a set time, that's why you would have to switch to another oral or another injectable after those 2 years. So what I was saying before with like the treatment, it is dependent on the medications because there is no one size fits all. Like I mentioned before, the 3 to 5 years of those oral medications, like your bisphosphonates, you can take that drug holiday, but then you have to eventually go back on it once the drug wears off in your system. And then just to review, or just to end, so osteoporosis medication selection is a careful choice between your patients, or between patients and your physicians, just taking into account all your individualized factors such as price, your sex, your other conditions, other medications you're on, because there are always other medication interactions to be aware of. And then it's also just to note that everybody on osteoporosis is not on medication, like we've learned today. And then just a healthy lifestyle balanced with diet, exercise, and preventative measures from falls all encompass osteoporosis treatment. So I hope this packet is just to help you be aware of the drugs out there. I'm not convincing you to go on one med or another. I'm just here to advise you and give you more information on the risks and side effects that may occur. And I really do appreciate everyone that was sharing their stories just to make everyone else aware of what may or may not occur. And thank you.
There's such a thing as a social worker that can be attached to our doctor's offices. So I don't know if any of you have the ability to tap into a social worker. I'm thinking of this because sometimes, you know how we have to talk things out and get information? I know you're here specifically for advising us on medications. I'm actually helping my father right now with a medication that his doctor just said he shouldn't be on. And so therefore, our job as our human beings is to be in tune with our bodies and ask questions. My problem is my dad can't ask the questions, so we have to go with him. He has aphasia. So we go with him and we say, Dad's blood pressure was really low. He actually fell because he had the low blood pressure. This was back in December. We have to realize our bodies are amazing, and they sometimes tell us the signs. And sometimes it can be really hard, and that's why we appreciate you here, because it's, Dr. Andrea, there's a lot out there that we don't necessarily know. Yeah. But our job, my mom just started taking an osteoporosis medication, and I'm already blanking on the title of the name of it. But I told her, I said, you better write down your symptoms, anything that's happening. You know, I appreciate you, that you spoke about, what, so we have to be in touch with ourselves and understanding that we, just check in,
I just want to mention that my osteoporosis was brought on by taking prednisone for quite a while. I came down with an autoimmune thing, and I took prednisone, and that takes your bones down.
Yeah.
And that's when I got osteoporosis.
Yeah.
How long did you take prednisone?
I took it for 4 months, and that was enough to do it.
Wow. I took it for a long time.
Yeah, it's a miracle drug. I mean, I couldn't, I might have died without it.
Yeah, but it's also can be a tough medication to take. I was on it for over 30 years.
It's a miracle drug.
Everybody's different.
I've seen it work for my grandmother. all that, but it does have its side effects. Side effects is your bones.
There are a lot of side effects with steroids.
Right, and so what one drug may be for someone, that may be not for someone else. And that's why when I talk to doctors advocating, she has low bone density and she already had a fall. So therefore, she's like, well, you should be on it. But you can also just be, write down some of the symptoms that you're experiencing, anything really.
Tell me that.
Yeah, there is a form that I really like, and I was thinking it's in this book. If it's not in this book, I'll be sure to bring it. I have it here. It's so good, whereby you're gonna, I'm sitting with it. So it's actually like asking questions, so it's prompting us to know what to ask. Of course, I don't have it right in front of me. Is this it? It's right here. It's stuck together. Handy checklist to remember all the questions you want to ask your doctor. Okay, and yes, you know how our time is so limited when we're with the doctor. So these are the questions, and I really like this, so I could, I'll be sure to get it to you, because this is from the Bone Health and Osteoporosis Foundation. I thought it was inside there. It could very well be in this book, but I didn't get a chance. And the other question I have for you, Dr. Andrea, do you recommend that we all should be taking a D3 supplement? Like, do you recommend that as a pharmacist?
I would recommend that because there are also different things besides bone health. It just helps with other things as well. So
Yeah, and what's the dosage that you recommend, if you don't mind?
it's usually 1,000 daily. Yeah, the D3.
And then do you also recommend it with the K2 that has to be with it?
K2. Oh, the test.
The, whatever the K2 is.
There's K2 and D3
So
at the same time.
They go together so they can, because a lot of times people can't metabolize just the D3. So they say that, I'm just saying we hear it over and over again. People are recommending the D3 with K2, and there's a reason, because then it metabolizes into the system better.
that I haven't heard about, honestly. But
Oh,
if it
okay.
does help with absorption, then I feel like there's no harm in taking it.
Yeah, my doctor recommended, I take that every day.
Yeah, and now they make that specifically D3 with K2.
Right.
Right.
What is it?
So it's a vitamin D, but it's vitamin D3, which is yeah. And then it's with K2, which part of, I'm not sure what K2 is, but
Yeah, that's what I take D3, but I don't know.
you may be surprised though if you take it, look on the back of it, Bobby, with regards to the K2. I'm only knowing it because of people talk about it.
K2?
But as a pharmacist, I'm just wondering what you're hearing and what recommendations are,
Yeah, I'm honestly not sure about the K2. So, because the D3 we give at the hospital, that's typical, but I have not heard about the combo K2.
Yeah.
If it helps with absorption, then I don't see any negative effects from taking it. It's as if they come as like a combo as well.
Yeah, and I think you heard this too, right? I think you know. Every 90 days, if we're making a nutritional change, it takes about 90 days to get into your system. So starting vitamin D3 today, and 90 days later, it's gonna stick and be with us, right?
Yeah, like stays constant.
Yeah.
Yeah, because it takes a while for your body to get adjusted to something.
As you said, everybody's different. In fact, Becky was actually told to stop taking calcium.
So the calcium would be different than the vitamin D.
But she was taking the calcium with D3,
Oh,
and
okay.
she was told to stop taking it.
Oh.
So that's everybody, be careful whatever you're taking.
Yeah, why?
The doctor just looked at her bone density and her blood tests and said, don't take it anymore.
And
So
Pat,
it was
thanks.
the best, maybe it was showing too much in her
Yeah.
system.
And Pat, thank
I don't
you.
know.
Right, and so everybody is different.
Everybody's different.
And we
Yes.
should follow the doctor's guidelines, and we could ask for a vitamin D test. And I know that vitamin D, right, to know our levels. And I know my doctor does it, and actually my
My
doctor
doctor
told me
does
to
the same
stop.
thing with my vitamins, and everything is in order with the chart.
Yeah.
So I'm very lucky.
You know, so not everybody has that test
I know.
because I guess it's an extra cost with a lab.
Yeah.
Yeah,
It's not
that's
what
your typical like
Yeah.
blood test.
Right.
Mhm. Well, I know it always seems like we always have a lot of questions on medications and not only osteoporosis medications. Thanks for like helping us with the maze of them.
Yeah, of course. I hope that helps.
Thank you. We really appreciate it.